Welcome to ANA Investigates, a podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Today, we'll visit the frontiers of vascular neurology, discussing an important but little understood category of strokes, embolic strokes of undetermined source, or ESUS. We'll hear from Dr. Hooman Kamel, Division Chief of Neurocritical Care at Weill Cornell Medicine. Dr. Kamel is co-principal investigator for the ARCADIA trial, which is testing anti-thrombotic strategies in patients with cryptogenic stroke and atrial cardiopathy. He was interviewed by ANA member Dr. Michelle Johansen, a vascular neurologist and assistant professor of neurology at Johns Hopkins. Here's Michelle.
All right, so welcome everyone. I am thrilled and honored to be interviewing Hooman Kamel today. He has just done remarkable research in the area of ESUS and particularly stroke etiology. And so I want to welcome Dr. Kamel to the podcast today.
Thanks for having me.
So for listeners who may not be familiar with this idea of ESUS, could maybe you spend a few minutes defining exactly what is meant by this term?
Absolutely. What ESUS refers to is a non-lacunar stroke that does not have a identifiable source. So we know that strokes can be due to diseases of the small arteries in the brain right in the area of damage, and that's referred to as a lacunar stroke or small vessel occlusion, or the stroke can be due to a clot that came from somewhere else, either from the heart or the great vessels or the large arteries that supply the brain. And ESUS refers to a stroke that is that appears radiographically to be from a distant clot, but the source can't be identified after standard testing. And so this concept is very similar to cryptogenic stroke, the old term, but the difference is that ESUS requires a certain minimum, amount of testing, whereas cryptogenic stroke could include someone who just never got any testing, right? They came in and for whatever reason they didn't get imaging of their vessels, they didn't get an echocardiogram. So that's the main distinction between cryptogenic stroke and ESUS.
So when we think about treatment, just to take a step back from diagnosis, but think about treatment with these terms of ESUS and cryptogenic and stroke of unknown source, what is the current standard of care? What are we doing currently for these patients that we're labeling as ESUS?
So I would say that the current standard of care for ESUS, you can break it down to diagnostics and treatment. I think diagnostically, a reasonable standard evaluation is to get a 12-lead EKG, just to look for, potential stroke etiologies like atrial fibrillation, to get vascular imaging of the head and neck. So whether that's by a CT angiogram, MRI, MR angiogram, TCDs and carotid Dopplers, or in rare cases, a sort of a catheter angiogram, but some kind of imaging of the vessels of the head and neck to see if there's significant, atherosclerotic narrowing of the vessels. An echocardiogram to look for potential cardioembolic sources, 24 hours of telemetry at a minimum to look for atrial fibrillation because some patients can have paroxysmal AFib, and then just a clinical evaluation for other rare causes like dissection and other rare disorders that can cause stroke. I think that's a reasonable diagnostic standard of care. As far as treatment, I think as of right now, based on the evidence that we have, a standard treatment would be an antiplatelet agent, a statin for the majority of these patients, blood pressure control if indicated, and then the sort of lifestyle counseling, smoking cessation, counseling them about exercise and diet. I think that would be standard of care for treatment.
Right, and those are all, excellent points. I know that as stroke neurologists, especially before 2015, when all these new trials came out about thrombectomy, it really was a classic joke of take 2 aspirin and call me in the morning, right? I mean, we seem to treat all of these patients the same with antiplatelet, except or in the event that you are to find atrial fibrillation. Do you think that there are tests or certain diagnostic maneuvers that should be sought after for someone who has ESUS rather than someone who has a cryptogenic stroke? Would you, for example, do more prolonged monitoring for someone who's been classified for ESUS versus cryptogenic stroke? Or do you think at this point, while we pursue further research avenues to further classify the ESUS group, that the testing is about the same? Is there anything that you would do differently for a cryptogenic stroke patient versus an ESUS patient?
In my mind, I think ESUS and cryptogenic stroke are essentially synonymous. I think of ESUS as a subset of cryptogenic stroke, and within cryptogenic stroke, the non-ESUS patients who technically have a cryptogenic stroke, they're either people who, for whatever reason, they're too ill. Goals of care dictates that you don't do a full workup, or it's people who have two or more etiologies. So they come in, they've got carotid stenosis and atrial fibrillation, and so they're technically cryptogenic because you can't be 100% sure which of those was the cause. So I think the question is, within ESUS, should we be doing more diagnostics than that basic set of diagnostics that I mentioned to you? I do think the one additional test that may be reasonable, it's not part of the consensus definition of ESUS. ESUS just requires, as of right now, 24 hours of telemetry. I do think it's reasonable in selected patients to do more prolonged heart rhythm monitoring. We have good evidence that looking for longer detects more cases of AFib. So, if you do a few weeks of heart rhythm monitoring via whatever technology, whatever type of monitoring system is available in your local setting, you will pick up more atrial fibrillation. And we think that that's helpful. We think that if you find the atrial fibrillation and the majority of U.S. neurologists, if you find AFib after stroke, they will begin anticoagulation. And we think that will help prevent recurrence, but we don't know for sure. And there are trials ongoing right now, not in stroke patients, but in patients who have implanted cardiac devices to see if anticoagulation actually reduces stroke risk in patients who have these very brief runs of AFib, like the kind that we pick up, on our post-stroke monitoring. So because of that uncertainty, I think, it's not absolutely required to do prolonged heart rhythm monitoring, but I do think it's probably reasonable to do that.
We talked a little bit about diagnosis of ESUS. We talked some about the terms of ESUS. We talked about how the standard of care right now is antiplatelet therapy. So tell us a little bit about ESUS research and this term and where it came from and how this has evolved over the past 5 years or so.
So the term ESUS came out in an editorial in 2014 that Bob Hart and a group of other very senior accomplished stroke researchers published in 2014, and they used this term ESUS again to try to operationalize cryptogenic stroke a little bit, right? To sort of exclude those patients who had incomplete workup or who had multiple potential causes, and to say, look, here's this entity. There's some simple, here's a simple definition of it, and we think that this group of patients, given that we think that the stroke was a result of embolism, will respond to anticoagulants, especially in light of all these, at the time, new oral anticoagulants that were coming onto the market. And that's the origin of the term ESUS. And it was hoped at that point, the authors of that ESUS editorial recognized that there was a lot of heterogeneity in the underlying potential causes of embolism. But they thought and hoped that all those different causes would still respond to anticoagulation. And the main, I think, the main result of research on ESUS in the past 5 years has been the completion of two very large, well-done randomized clinical trials of anticoagulation with these non-vitamin K oral anticoagulants versus aspirin in patients with ESUS. And unfortunately, despite what was hoped for, the results of those trials did not show an overall benefit of anticoagulation among all patients with ESUS. So I think that's been the main, the main therapeutic kind of line of work on ESUS over the past 5 years, and sure. The result is that we don't think that if you just take the average ESUS patient, they're not going to benefit from anticoagulation. And at the same time, though, there's been a lot of research on trying to better understand the underlying etiologies of ESUS, and that's been kind of going in parallel with those trials. And so I think we do have a much better understanding of what the underlying causes of ESUS are and how we can maybe target them on a case-by-case basis.
Okay, yeah, those are all excellent points. So just for those who are listening, those two trials that you mentioned, so the Navigate ESUS trial and the Respect ESUS trial, and just like you said, they were using some of these NOACs, and using apixaban is still ongoing, and it showed that there was no benefit in using either a NOAC or compared to aspirin in those patients who were identified as ESUS. And why do you think that was? Why do you think that for those of us who believe that there is something important in doing a better job in classifying these patients who fall within ESUS and finding the etiology, and potentially the big notion being that maybe some of these ESUS patients are in fact having clots form that would classify as cardioembolic, and we know that patients with atrial fibrillation at least appear to respond to some sort of anticoagulation to prevent recurrent stroke. Why do you think that the results were null for both Navigate ESUS and Respect ESUS?
No, I think that's the million-dollar question. My thought, and this is not an original thought, I think a lot of people shared this thought, is that we know anticoagulation works very well for cardioembolic sources. We know that from the AFib literature. It probably works for patients with very low EF. We know it works for patients with mechanical valves. But it doesn't seem to work well for atherosclerotic disease. So, for example, the WASID trial didn't find the benefit with anticoagulation over aspirin, and that was a trial of patients with intracranial atherosclerotic disease. So, if a substantial proportion of patients with ESUS have occult atherosclerotic lesions, either in the aorta or the great vessels or the intracranial vessels, then the anticoagulation probably doesn't work for those patients, and so any benefit of anticoagulants in the patients with an occult cardioembolic source is either washed away or perhaps even offset by the patients with an atherosclerotic etiology of their ESUS. It's hard to know because it's very circular, right? By definition, we don't know the source, and so you're making sort of assumptions. Now we are seeing more and more work about biomarkers, and I think we're getting better at being able to identify sort of underlying atherosclerotic plaques that may have been the cause of stroke, or identifying cardiac conditions that can be the cause of stroke. So I do think we're getting more and more of an idea of how to sort patients into, hey, this patient technically has ESUS, but they probably their source was athero, versus this patient technically is ESUS, but probably the source of their stroke was the heart.
So you mentioned this idea about biomarkers and trying to do a better job of categorizing and diagnosing these patients who have ESUS, and that leads us to the ARCADIA trial, which we're all very excited about. So hopefully you'll be able to relay to our audience today, what is the ARCADIA trial?
Absolutely. So the underlying premise of the ARCADIA trial is that some cases of ESUS are due to thromboembolism from the left atrium that occurs in the absence of apparent atrial fibrillation. So, the work that we have been doing for the past 5 years and other groups are doing, it's becoming increasingly clear that that you can have a thrombogenic left atrium that can cause clot to form and embolize the brain even before atrial fibrillation first appears. So, from decades of cardiology work, it's become clear that AFib doesn't come out of nowhere. It usually arises in the setting of a diseased atrium, atrial dilatation, fibrosis, lots of other derangements. And so it's possible that those underlying atrial abnormalities can lead to a clot forming even before AFib first manifests. And if that's the case, that would explain a lot of sort of paradoxes about AFib and stroke. And at the same time, our group and other groups have looked at markers of underlying atrial cardiopathy or underlying abnormal atrial substrate, and we're finding that these markers are associated with stroke risk, and especially embolic-looking stroke risk, even in the absence of atrial fibrillation, and independently of atrial fibrillation. So, based on that premise, and given the parallels between atrial cardiopathy and AFib, our thought was that ESUS patients who have underlying atrial cardiopathy may respond to anticoagulant therapy more than aspirin.
So tell us, what are the inclusion-exclusion criteria? How are you guys defining an atrial cardiopathy in your population?
So we're taking the ESUS population, just like the Navigate ESUS and Respect ESUS trial did. We're defining it in almost the identical way, but then we are only enrolling patients who have evidence of atrial cardiopathy. And one challenge is that, there's no agreed upon definition of atrial cardiopathy. So we used biomarkers that we had studied in our pilot data and that for which we had found associations with stroke. And so we're using 3 different biomarkers. One is left atrial size on echocardiogram. One is NT-proBNP, which is a natriuretic peptide that's released by myocytes when they're, injured or under stretch. And then the last is left atrial abnormality on EKG. And we based on our pilot data, we thought that those biomarkers were all important because they look at different kind of complementary aspects of atrial dysfunction. And so we defined our eligibility criteria to say if you met any of one of those 3 criteria, you would be eligible to be enrolled.
And then what are the 2 arms of the study?
So patients get randomized to either aspirin, 81 milligrams per day, or apixaban, 5 milligrams twice daily, which is the sort of standard dose.
Okay. And then what are your endpoints for the trial?
The outcome is a recurrent stroke of any type, so ischemic or hemorrhagic.
Okay. All right. And so you and the team are undergoing ARCADIA, which is really important, and you're using these 3 defined biomarkers, as you say, to classify this notion of atrial cardiopathy and to capture ESUS patients. Are there any other trials or exciting research ongoing in the field of ESUS besides the ARCADIA trial?
Yeah, lots of things. There's the Atticus trial that's happening in Europe, where it's not quite the same concept as ARCADIA. I think they're taking a more broader definition of sort of cardiac abnormality. So they're enrolling ESUS patients with PFO, with high CHADS2 VAS score, which is a risk score used to predict stroke risk and atrial fibrillation. And they're randomizing patients to apixaban or aspirin, and their endpoint is radiographic brain infarction on MRI rather than a clinical endpoint. So it's a smaller trial. I think they're aiming for 500 patients, but that'll be very, very interesting to see the results of that, and I sort of wish them luck. There's a lot of research, again, ongoing on trying to identify the underlying causes of ESUS. Many groups are publishing on different biomarkers of vulnerable plaque. So, the current definition of ESUS and cryptogenic stroke, it's all based on the degree of narrowing of the arterial lumen, right? So if you have more than 50% narrowing of an upstream artery ipsilateral to the infarct, then that stroke is classified as being due to large artery atherosclerosis. But we and many other groups are finding that patients with less narrowing than that, but who have very vulnerable looking plaque based on different biomarkers, like for example on MRI, that may be a risk factor for ESUS. So I think there's a lot of work to be done on that. The question of PFO and ESUS is, I think, one that's very much in play and is an exciting area of research. Right now, if someone comes in and they have a PFO and a stroke and there's no other cause, very often that stroke gets classified as ESUS. But based on the PFO closure trials, it seems like some of those patients have a PFO-associated stroke. And so how to define that? What are the criteria for PFO-associated stroke? I think we'll see a lot of really interesting work coming out on that.
So what is the stroke recurrent rate for an ESUS patient in general? It's obviously hard to capture if we think that there's potentially different etiologies leading to ESUS, but how does it compare to, let's say, a large artery, atrial thrombotic stroke, or someone who has known atrial fibrillation?
That's a really good question. I think based on observational studies, the reported range was like 3 to 7%, and then the two big trials, Navigate ESUS, for example, the recurrence rate was 5%.
That's outstanding. Those are great points. And there may be some patients who feel uncomfortable with this notion that the cause of their stroke has not been identified, right? So as doctors, we can say cryptogenic versus ESUS, what that means, and try to go about targeting research that looks at what the actual etiology of the stroke is. But for those patients, when we're at their bedside and saying, well, we're not really quite sure, this is what we think, sometimes it can leave them feeling a little baffled and not quite sure how to proceed. How would you advise the treating physician who is maybe taking care of an ESUS patient, how they can discuss this concept with them?
That's a really good question. I think it's something we all struggle with. My general approach is to, I think you have to walk a balance, right? You have to explain that, what the standard evaluation is and what the results are. And if nothing shows up on that standard evaluation, I generally start talking about risk factors as well as actual mechanisms. And I explain that, in these cases, often where we can't find exactly the source of the clot, we still have proven methods to generally reduce vascular risk, and that if we institute all these treatments as a team, the patient doing their part and the doctors doing their part, then we can substantially reduce the risk of recurrence, and the chances are the patient will be just fine and never have another stroke again. So that's the way I kind of try to balance out this idea of like informing the patient about their exact diagnosis, but also not sort of scaring people unnecessarily.
Okay, so as we conclude today, what would you say are the three main points? If someone were to put us on 10 speed and fast forward to the end, what would you hope that they would take away from our discussion today?
Okay, so three key points. One, ESUS is common. About a fifth of patients with stroke have ESUS, and it has a high risk of recurrence. So that's point number one. Point number two is that, based on the current available evidence, the standard of care for ESUS patients is a single antiplatelet agent, a statin as indicated, and blood pressure lowering as indicated. And then number three is that ultimately we are hoping for more effective personalized treatment based on a better understanding of the underlying risk factors and personalized approaches to target those risk factors.
Dr. Kamel, I want to say thank you from all of us who will be standing by excitedly to hear the results from your trial, the ARCADIA trial, and the work of others in this field. I think it's a really important field. It's a very exciting time to be a stroke neurologist. There's lots of new things that we can do now. And I believe that as we move the field forward, we're going to be able to offer that patient who's sitting at the bedside, unclear of what the diagnosis is, more information, and hopefully that will translate into not only diagnostic strategies, but eventually treatments. So thank you so much for taking the time out of your day to speak with us today about this topic that's really important, and I think in the next few years is going to change the face of stroke care.
Thank you. It was my pleasure.
That was Dr. Hooman Kamel, Division Chief of Neurocritical Care at Weill Cornell Medicine, interviewed by Dr. Michelle Johansen, a vascular neurologist and assistant professor of neurology at Johns Hopkins. That's it for our show today. You can hear more of ANA Investigates and submit your ideas for future episodes by clicking the Education tab at myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us for this episode. If you're not already a member of the ANA, please visit myana.org to learn more about the benefits available to ANA members, including access to an array of educational programs and resources, like online CME courses, webinars, the ANA's journals, the Annals of Neurology and the Annals of Clinical and Translational Neurology, and more. Dr. Adeline Goss is our host. Our producers are Drs. Romer Giucaden, Adeline Goss, Michelle Johansen, Clifton Gooch, Danny Vega, Megan Ritchie, and Jim Sigler. This is your editor, Jen Hurley. Copyright, the American Neurological Association.